Good afternoon. My name is Giacomo Grasselli and from Milan in Italy. And in this, the next 25 minutes, half an hour, I will discuss with you some relevant aspects of respiratory mechanics, ventilation settings, and the use of rescue treatments in critically ill patients with ARDS due to COVID-19. These are my conflicts of interest. So, just a brief introduction on what happened here in my region, Lombardy, which is a region in northern Italy near Milan. We are 10 million people, and for 10 million people, before the pandemic, we had something like 750, 800 ICU beds in total. So less than 3% of the total hospital beds were dedicated to ICU patients. And we also have in Italy, probably you know, quite a good, quite a large ECMO network, and 5 ECMO centers are located in Lombardy. So when the pandemic started, we took advantage of this experience to organize our network. So we established this network on February 20, which is the day when the first patient was diagnosed. And you should know that this patient had no relationship with China. He was a patient who was never had any relationship with China, didn't travel or no contact with Chinese people. So this was an autochthonous case. And this is why we were scared. And so we created a task force at the regional government, and I was in charge of the central coordination of this network, and I still am. And our goal was to monitor the ICU resources, to create a network of ICU beds that could admit COVID-19 patients, and also to collect data and share treatment protocols. So this is what happened in Lombardy. So we had the first pandemic wave with a peak number of ICU patients with COVID-19 of 1,500 around mid-March 2020. Then the second wave with a peak number of patients of 940 in November 2021, and another 900 patients during the third wave at the beginning of 2021. And this is the total activity of the network in Lombardy, so in our region, from February 20 till yesterday, basically. So we admitted to our ICUs almost 12,500 patients, with this overall mortality around 39%, and mortality is decreasing from the first to the third wave. So a very important activity of our network, and this is what I want to discuss with you in the next part of the presentation, was the research activity. As I told you, we collected a huge number of data, and we were able to publish these 2 papers in JAMA that basically were the first papers reviewing a large cohort of COVID-19 patients in the Western world. So from in these 2 papers, we studied the baseline characteristics and risk factors of the patient associated with patient outcome. So talking about pathophysiology of the disease, you all know that there has been and there still is a big debate among the experts if COVID-19 ARDS is similar to classical ARDS or it's a special peculiar entity. And you all certainly know that Luciano Gattinoni and John Marini proposed this idea of the 2 phenotypes of the disease. One is called type L, which means low elastance or high compliance of the respiratory system. So compliant lungs, relatively low intrapulmonary shunt, and low recruitability. And the type H, so patient with high elastance, low compliance, stiff lung, high intrapulmonary shunt, high recruitability, similar to what we are used to think of ARDS. So the idea was that COVID-19 was a specific disease, and that these two phenotypes should be managed differently from the ventilation point of view. Then I have to tell you, and I will try to demonstrate in the next slides, that this view of the two phenotypes has been challenged by subsequent studies. And then the majority of investigators basically now agree that COVID-19 is indeed ARDS. So we have proof from lung pathology of patients who died from COVID-19. This is a very important paper published at the beginning of the pandemic in the New England Journal of Medicine. They examined the lungs from 7 patients who died of COVID-19, and they compared them with lungs from patients who died for H1N1 pneumonia and from uninfected controls. And what they saw is that the main pathological alteration in COVID-19 and in H1N1 is diffuse alveolar damage, which I want to remind you is the pathological hallmark of ARDS as stated by the Berlin definition criteria. And what is peculiar of COVID-19 is the endothelial damage. We know that there is this view of immune thrombosis. COVID-19 is associated with an intense inflammatory reaction and an intense dysregulation of the immune system with activation of decoagulation that leads to endothelial injury, microvascular thrombosis, and neoangiogenesis. So we wanted to study the pathophysiology of this disease, and together with Marco Ranieri and other investigators in Lombardy and in Emilia-Romagna and in Rome, Massimo Antonelli, for example, we published this paper in Lancet Respiratory Medicine on 300 patients with COVID-19. All patients underwent protective mechanical ventilation, basically volume control ventilation. The median PIP value was 13 centimeters of water. They all had moderate to severe ARDS. And for each patient, we measured the static respiratory system compliance, ventilatory ratio, which is a proxy of dead space fraction, and the D-dimers that are a proxy of endothelial activation and thrombosis. And in a certain number of these patients, we obtained also CT scan to measure, to account for total lung weight. And in a subset of these, we also did CT angiograms, and I'll show you some images later. And then we also compared the data from COVID-19 patients with data from a control group of patients with classical ARDS. And the control group was taken from the LungSafe database and the Berlin definition database. So these are the main results of the study. You can see here that COVID-19 patients have median respiratory system compliance values slightly higher than classical ARDS. You can see here 41 versus 32 ml per centimeter of water. But as you can see, values of compliance are really dispersed, and only 5% of the patients with COVID-19 had compliance values higher than the 95th percentile of the patients with classical ARDS. So you can see that both in COVID-19 and in classical ARDS, compliance is very dispersed. We didn't see a bimodal distribution of compliance. So we did not find any evidence of the two phenotypes. We didn't find a difference in total lung weight between COVID-19 and classical ARDS patients, while COVID-19 patients had quite high D-dimers and an increased ventilatory ratio, which means an increased dead space fraction, which is correlated with D-dimers. And this is expected because the higher the endothelial, the vascular damage, the higher should be the dead space fraction. So these are images taken from our paper. We basically subdivided the patients in 4 subgroups according to the median value of D-dimers and the median values of compliance. So we had the groups with low D-dimers, low compliance, patients with low D-dimers and high compliance, and patients with high D-dimers and different levels of compliance. And you can see that patients with high D-dimers have a lot of these purple areas, which are areas of hypoperfusion, indicating that high D-dimers represent a marker of endothelial activation and of diffuse thrombosis, hypoperfusion of the vascular bed in the lung. And you can see here on the right side of the slide, this very nice, I think, three-dimensional reconstruction of the pulmonary arterial pulmonary vascular tree. And all the red spots are thrombi in the pulmonary circulation. So you can see here in these patients with high D-dimer, a very diffuse thrombosis of both large and small pulmonary vessels. What was very interesting in our paper is that the overall mortality of the cohort was not very high, I mean 35%, which is lower than reported in most serious, but we observed a very important difference across the different groups of patients, namely patients with high D-dimers and low compliance. So patients that have both endothelial damage, vascular damage, high D-dimer, and parenchymal damage, alveolar damage, low compliance. These patients, in patients in whom vascular and parenchymal damage coexist, mortality is much higher. You can see here, this is Kaplan-Meier curve. Survival is significantly lower than in all other patients. Our data were then confirmed by other studies. For example, this is a very nice paper published in the Blue Journal. It's a research letter, actually. They assessed the respiratory mechanics in patients with and without COVID-19, and they compared the recruitability. And what they saw was that respiratory mechanics in COVID-19 is really heterogeneous and not much different from non-COVID ARDS. Recruitability was, again, really variable between patients, and there was no correlation between the duration of symptoms and compliance, and they did not identify phenotypes. This is another paper by Domenico Greco and Massimo Antonelli. They matched 30 patients with COVID-19 with 30 patients with ARDS from other etiologies, and the patients were matched based on PF ratio, PEEP, and tidal volume. And again, they confirmed that the respiratory mechanics in COVID-19 is quite heterogeneous, and that compliance and ventilatory ratio are slightly higher in COVID-19, but again, no demonstration of the two phenotypes, variable potential for PEEP and potential of recruitment. And they also showed that most patients with COVID-19 have a good response to PEEP in terms of oxygenation, even if they have a low potential for lung recruitment. And interestingly enough, in the secondary analysis of the LungSafe database, these investigators showed that also in non-COVID ARDS, LungSafe, also in non-COVID ARDS, compliance values are highly variable between patients, and then more than 1/3 of the patients have compliance values higher than 40 ml per centimeter of water. Then if you look at the relationship between compliance and PF ratio, this table is taken from the supplementary material of our paper in Lancet, and you can see that apparently from the table, in classical ARDS, you see a clear relationship between compliance and oxygenation compromise, while if you look at median values, this relationship is not seen in COVID-19 ARDS, but median value do not help to evaluate granular data, because then if you go a little bit deeper into this relationship, you can see that, for example, in the paper by Greco, also in COVID-19, there was a significant relationship between compliance and PF ratio, while, for example, in classical ARDS, these are data from the LungSafe study, you can see that there is a slight relationship, but you can see the dispersion. So the strength of the association is very low. So again, both in COVID-19 and classical ARDS, the relationship between compliance and PF ratio is not so strong, and it's similar between the two entities. So we tried to review most of the papers that report data on gas exchange and ventilation parameters, and we published this scoping review in Critical Care. We pooled the data from 26 studies on more than 14,000 patients, and you can see here that in most of the papers, PEEP value was reported, while, for example, respiratory rate and compliance were reported in lower number of patients. Then we analyzed the data, and this is what we saw. Basically, what I can say is that the mechanical ventilation setting in COVID-19 is very similar to classical ARDS. So in most of the patients with COVID-19, patients are ventilated with protective settings. You can see here tidal volume between 6 and 7 ml per kilo. And you can see here the lung safe data for reference, and plateau pressure and driving pressure within the protective range in basically all the studies, and relatively high levels of PEEP. You can see that in all studies, PEEP was above 10, and in most of them above 12 centimeters of water, while in the lung safe study, the median PEEP value was 8.4 centimeters of water. So this is to say that in the vast majority of the patients with COVID-19, it's possible to implement protective mechanical ventilation with low tidal volume and low pressures, and a relatively high level of PEEP are used. And in this table, we reviewed the frequency of use of rescue treatments. And what I want to show you is that both neuromuscular blockers and prone positioning are used very frequently in COVID-19, and much more frequently than in the lung safe, in the population of ARDS from other etiology. You can see here that most of the studies have a use of prone positioning above 50% of the patients, while in the lung safe database, only 7.9% of the patients with ARDS were prone. So we tried to study the use of prone positioning in a large cohort of patients with COVID-19. So we analyzed more than 1,000 patients from an observational study that we still have ongoing. And this is a retrospective study, multi-center, 24 ICUs, more than 1,000 patients invasively ventilated from the first pandemic wave. You can see vast majority of the patients with moderate to severe ARDS, and we had a very high frequency of prone positioning, 61% of the patients. And prone patients who were turned prone had more severe disease. And for this reason, they also had higher mortality. Then in a subset of these patients, we analyzed the response, the physiological response to prone positioning. So in 80 patients, we took PF ratio, compliance values, and ventilatory ratio values before prone positioning, during the prone positioning session, and at the resupination. And we found that barely 80% of the patients had a significant response in terms of increase of PF ratio. And while there was basically no change in respiratory system compliance and the ventilatory ratio associated with prone positioning. And we also saw that patients who responded to prone positioning in terms of increase in oxygenation had better outcome compared to non-responders. So these are only observational data, a subset of patients. They need to be confirmed. There are studies ongoing, but again, prone positioning is very frequently used, and it is certainly effective in improving PF ratio, and it might be advantageous in terms of patient outcome. So I like a lot this viewpoint published by Eddie Fan, Laurent Brochard, Caroline Calfin, Eyal Ferguson, Brody, and Slatsky in COVID-19 in Lancet Respiratory Medicine. Basically, what they say is that there are reports of phenotypes in COVID-19. These reports are very interesting, but they could be misinterpreted. And what they say is that the larger studies that I showed you suggest that patients with COVID-19 have similar respiratory mechanics than patients with ARDS from other causes, and that COVID-19 ARDS is in the end ARDS, and so that in all patients with COVID-19, like in every patient with ARDS, protective mechanical ventilation is recommended. So the last part of the presentation will cover the issue of ECMO in COVID-19. These are the last guidelines from WHO, and they say that that ECMO can be considered for COVID-19 in patients with severe hypoxemia, and these criteria are quite similar to those adopted in the Eolia trial. And these are the last guidelines from the ELSO organization, and again they more or less follow the Eolia trial criteria. They just point out that we need to adjust our ECMO capability to the capacity of the system, to the contingency capacity of the system, which is related to the number of patients requiring ICU admission, and so to the stress imposed to the healthcare system. So this is a very nice editorial in Lancet Respiratory Medicine that says that when we want to implement an ECMO program or simply to start ECMO in a COVID-19 patient during COVID-19 pandemic or other outbreaks, we need to have careful planning of the ECMO activity, a very careful resource allocation, and we always have to be aware of the infectious risk. So we need to implement complex therapeutic interventions like ECMO while adhering to strict infection control measures. So the first reports from the first stages of the pandemics were, I have to say, quite discouraging. You can see here a very low use of ECMO, and in most of these of the first reports, a very high mortality. So at the beginning of the pandemic, the current view was, okay, ECMO is not useful for COVID-19. Then a number of studies have been published. These are the data from the EuroELSO, published by Broman and Roberto Lorusso. You can see here the number of ECMO runs ongoing during the different phases of the different waves of the pandemic. This is the number of the percentage of deceased of patients who are successfully weaned from ECMO and of patients who die on ECMO. And you can see that during the first wave of the pandemic, survival was better than during the second wave, where the percentage of patients who are weaned is more or less similar to that of the patients who are who die. And in particular, you can see that in the first wave, the 53% of the patients survive to hospital discharge after being weaned from ECMO, while during the second wave, only 44% of the patients survived. So we have observed a decrease in survival in ECMO-treated patients across the two waves. And these data are not definitive because, as you can see here, when these data were published, 25% of the patients of the second wave were still on ECMO. Then there are the data from the ELSO registry, more than 1,000 patients with a median age of 49 years and better mortality, around 37 to 39%. So very similar to what is reported in the Eolia trial. Then there is the French experience at the Sorbonne University. So Alain Combe, basically, as you know. What they showed that these patients were very severe. Patients put on ECMO were very severe with a PF ratio median of 60 millimeters of mercury. And 80% of them have been prone on ECMO. And if you compare, these patients were more severe than the patients enrolled in the Eolia trial. And in this paper, you can find the ventilation parameters, blood gas values, and all the details about the management of ECMO patients in COVID-19 in Paris. Then from the same group, what they show is that, again, the mortality of the patients with COVID-19 treated with ECMO is comparable to Eolia trial. You can see here 36% of mortality. They have quite a long duration of ECMO, around 20 days, and a very long median ICU length of stay. Then always from France, this multi-center cohort study describes the ECMO network organization in the Île-de-France region, 300 patients. These are the criteria for starting VV ECMO. You can see here it's the same criteria recommended by WHO and more or less the same criteria recommended in the Eolia protocol, and the contraindication here. And this is the multivariable analysis. You can see that the vast majority of the patients were prone before ECMO. Median PF ratio before ECMO was 60 millimeters of mercury, and 90 days mortality was quite high, 54%, and the factors associated with mortality were age, SOFA score, the time between intubation and ECMO, and the experience of the center. And as you can see here, another scary data is that more than 40% of the patients had a major bleeding event. And this is the last paper that has been published on ECMO in COVID-19. It's a research letter published in the Blue Journal by Christian Karaganidis. So this is the German experience, and as you can see, very bad survival data. You can see here on almost 800 patients of mean age 58 years, so older than the patient reported in the ELSO registry or in the French case series. And what they saw was when they observed very high mortality in all age group. Clearly, mortality increased with age. So 56% in patients below 50 years old of age, 67% in patients below 60 years, and then more than 80% in patients older than 60 years. And again, a relationship between mortality and the time interval between the start of mechanical ventilation and ECMO, with better outcome for patients who are put on ECMO less than 3 days after the start of mechanical ventilation. And this is basically my last slide, just to tell you that there is also this possibility. There is a small but growing experience of lung transplantation in patients with sequelae of acute ARDS from COVID-19. This is the first case reported in Lancet Respiratory Medicine. Then there are other small case series, mostly from Vienna, some patients from Milan, from Italy, from my center, and some patients from the States and in Canada. And all the lung transplantation center are now implementing a lung transplantation program for patients with COVID-19. But it's very difficult to identify the right patient and the right timing for transplant allocation. So in conclusion, what I would like to say is that COVID-19 ARDS is in the end ARDS. So we have to apply in all patients protective mechanical ventilation, that these patients, due to their severity of hypoxemia, frequently need rescue treatments, in particular prone positioning and neuromuscular blockade. And in an increasing number of patients, ECMO is being used as a rescue for refractory hypoxemia. Clearly, the topic, the issue of resource allocation is extremely important in the context of a pandemic, and we still have a lot to learn. So thank you very much for your attention.